Good evening, everybody. It's 7 o'clock. Welcome to the fourth of a series of 5 Royal College of Pathologists webinar updates on various aspects of COVID. For any newcomers, the format is that we have a guest speaker who will talk on a specific topic for 15 or so minutes, and then we'll have a question and answer discussion also for around 15 minutes. It's best if you can keep your microphones muted and your videos off. That's the best connectivity. I should also let you know we're recording this session, so you will be able to view it in about a week's time from the RCPath website. If you do have questions, then please post them using the Q&A function. If you type them in there, then I can see them and I can relay them to our speaker after he gives his talk. So tonight's topic is one that we didn't cover because when we did the first series of webinars on COVID, the concept of long COVID hadn't yet been born. But several months later, it's now apparent that this is a significant problem. So this isn't just an update, this is an introduction as well to the concept of long COVID. I'm delighted to welcome a local colleague, Professor Ian Hall, who is a Professor of Molecular Medicine at the Nottingham University Hospital's NHS Trust and is the Director of our NIHR Biomedical Research Centre. So without further ado, I'll hand over to Ian. So the screen's yours, Ian.
Well, it's great to be able to talk to you. I gather we've got quite a mixed audience, so I apologise if some of the stuff I say sounds a little bit simplistic or some of it a bit overcomplicated. I'm very happy to answer any questions afterwards. And so what I'm going to do is I'm just going to rattle through quickly a very brief update of where we are in terms of COVID in general, and then I'm going to spend most of the time talking about issues to do with long COVID. And let's get the next slide up. So I guess I first heard about COVID almost exactly a year ago when some colleagues of mine who work at Ningbo No. 1 hospital in China. I have a PhD student over there, actually, who's a respiratory physician, contacted us about this new viral pneumonia. And these are actually some slides taken from one of the early cases that they saw back in Ningbo No. 1 hospital. And because we have a link with the hospital, we were able to get some advanced information about what was clearly quite a nasty viral pneumonia. And for those of you who are used to looking at CT scans, you can see there's quite extensive bilateral changes in this scan, and at that stage we hadn't had a case in the UK, but it was very clear that this was something which was fairly transmissible, and I don't need to tell everybody that actually it's spread all around the world since then. And here's the latest data from the coronavirus data website as of a couple of days ago when I downloaded it. So what you'll have seen is that the numbers of cases are dropping in most places now. So the numbers of positives have been dropping off since about the middle of January, and that's being reflected in a reduction in hospital admissions shown on the right-hand side of this slide. And we're actually starting to see some fall off now in the number of people dying of this, but actually still really quite significant amounts of activity. So this is obviously the second wave that we've been working our way through, which is hopefully starting to fade away. And of course, you can get all the information about where the differences in rates are regionally, and actually it's pretty widespread still. What we saw in the early part of the second wave was that most of the cases were in the northeast and northwest, and London was relatively spared. But now actually, as most people I'm sure will know, the numbers of cases are driven up in London, etc. And it's only really the Highlands of Scotland and some of the west of the UK which has seen relatively lower rates. So I guess from my point of view, there are a number of key questions. I put them on here as research questions, but they're important from a clinical point of view. And so some of these relate to long COVID and some of them are more general. So I still don't think we're completely sure about what the most effective ways are to prevent transmission, although we've obviously got a lot more information than we had a year ago. We still could do with an accurate point of care test, because you know, I do my lateral flow tests, as most people do, twice a week, and they're fairly fast, but they only give us about 50 to 60% sensitivity. So we need rapid tests. We are going to have to do some quite rapid clinical studies looking at the best way to use effective vaccine, the vaccines that we've got, and work out how to modify them as needed as new strains become apparent. We still don't know all of the treatments which are likely to be effective for acute disease, although we know some of them. But increasingly, it's becoming clear that in the medium to long term, the main work is going to be to manage the acute cases, which presumably will be much lower as vaccines and come into a much broader use. But we're also going to have to manage the consequences of those who've had COVID. And given that that's now over 15% of the population who've got antibodies, then there are lots of people out there who are struggling still with symptoms and signs from having COVID in the past. And I'll talk a little bit about that later on. And what we don't really yet know, or what the risk factors are for developing so-called long COVID, what are the consequences of having that, other than the fact that we've now got about 9 months worth of follow-up data, and most importantly of all, are there any interventions that we can develop which will help in terms of speeding up the recovery for people who've got long COVID. So we know about acute treatments. I'm not going to labour this because I think you've already had a presentation about it, but this is data from the recovery trial, just showing that dexamethasone in patients who required invasive mechanical ventilation or were oxygen dependent did better. Patients did better if they were on dexamethasone. And the recovery trial continues to study a whole series of additional interventions. It's shown futility for some of those. It's due to report on the anti-IL-6 drug tocilizumab imminently within the next few days, for example. So we will get more information about acute drugs which work in the acute setting. And one of the roles I have is I sit on UK CTAP, which is responsible for feeding drugs through into the different platform trials that we've got to manage acute COVID. And actually, it's probably worth highlighting that the UK is the envy of the international population because of our ability to rapidly deliver definitive studies, recovery being the best known example of that, but there are a number of other platform trials, REMAP-CAP, Principle. The latest one to start up, which is relevant to this evening's topic, is HEAL-C, which is going to be dealing with post-hospital interventions. I think the other thing that we've done a pretty good job of is coordinating activity across the country for sample collection and data collection. And this is data showing a genome-wide association study, which happens to be one of the areas of research that I'm fairly active in, although I'm not particularly involved in the COVID work. And this is data which came out last year showing the first GWAS study done for COVID. And I'm not going to go through this in detail. If anyone's interested, I'm quite happy to answer questions about it. But it shows quite clearly, for example, here on chromosome 3, that there is a very strong signal. So there are risk factors from not only from an epidemiology point of view in terms of pre-morbid conditions, etc., but also background genetics, and which can predict your risk of developing COVID disease sufficiently severe to put you in hospital. We don't have the same information yet about long COVID, but I expect that to become apparent over the next 6 to 9 months or so. So what is long COVID? So many patients who have had an acute episode of COVID have ongoing symptoms after the acute phase of illness resolves, and these persist often for months. I've got patients I'm aware of who've had symptoms dating back to last March. I'll talk a bit more about what those symptoms actually are, but the commonest ones that are described are of ongoing fatigue, breathlessness, difficulty in concentrating, mental health issues, and a whole range of others. And we don't know much about the underlying pathogenesis of long COVID. I'm going to tell you a little bit about some of the studies that are ongoing, many of these involving imaging approaches, trying to work out what the underlying pathological processes are. And of course, as I've already hinted at, the samples that we've been able to collect will enable us to look at the genetics and indeed other biomarkers which might predict the development of long COVID. And at the moment, we have no proven interventions which have been shown to improve the outcome in this condition. So how common is it? It probably affects around 1 in 20. It depends a bit on what the definition that you use is. This is data taken from the Zoe Tracker app, actually, from late last year. And I think the definition they used here was continuation of symptoms beyond 40 days. And about 1 in 20 people have at least some ongoing symptoms. And we know a little bit about how that sort of plays out. So as you might predict, those people who've had a prolonged hospital stay and had severe disease are more likely to have symptoms in the long term. But interestingly, there are a fair number of people out there who never got ill enough to come to hospital, but have still been left with quite debilitating symptoms after a month, or actually persisting much longer than that. It's probably worth saying that there is going to be some overlap with patients who have been through critical care who have had an ARDS-like illness. So before COVID became an issue, we used to see patients who went to the ICU with ARDS in the context perhaps of having had influenza A, and many of those people were left with structural lung disease and significant disability which persisted long term. But there are some specific features which seem to be commoner in patients who've had COVID as opposed to those who have had prolonged stays due to ARDS. And this is data which actually has only just been released. In fact, the paper has not been peer reviewed yet, so I've just put the reference in there for the preprint reference for it. But it describes a meta-analysis of multiple studies looking to see what the commonest symptoms that are being described by patients fitting a long COVID definition. And what you can see, as I highlighted earlier, that fatigue, continuing cough and breathlessness, etc., are quite common. Headache seems to be quite common. Failure, lack of taste, which is what ageusia is, takes a while to recover. Hair loss is a feature which has been described in quite a few people. And then there's a whole bunch of other symptoms as well. Quite often gastrointestinal symptoms seem to be persistent. There seems to be a subgroup of people who have often a rather atypical presentation with COVID, with a lot of GI symptoms, who go on to have longer term symptoms from the GI tract as well. What's the evidence that these are actually driven by ongoing inflammation? Well, it's pretty weak at the moment, but some of these patients do have increased markers of ongoing inflammation. So D-dimers remain elevated in about 20% of them, CRP in just under 10%, and IL-6 actually remains elevated in some people, even at these sort of relatively later stages in the disease. So at least some evidence that there's ongoing inflammation based on biomarkers. What's the evidence that long COVID actually is producing tissue damage? So this is 2 CT scans in someone who had an acute episode of COVID. Shortly afterwards had a little bit of ground glass shadowing, which you can see in the upper scans on this slide. And then 3 weeks later had got really quite extensive lung fibrosis with some honeycombing developing, which is the 2 lower panels. And this is obviously after the acute episode. So I'm a chest physician, and it's very clear to us that we're seeing a large number of people now presenting with structural lung disease, having previously had an acute episode of COVID. The best predictions from my colleagues are that we're probably going to double the workload in interstitial lung disease in this country as a consequence of post-COVID lung fibrosis. And we don't know whether or not any of the drugs which work in other forms of lung fibrosis are effective in this condition. And also we don't know what the long-term progression of the disease looks like, but looking at the sorts of changes you can see on that CT scan developing after an acute phase of illness, it's difficult to believe it's all going to resolve very rapidly. Of course, COVID was first recognized, as I showed you earlier, as a viral pneumonia, but actually produces a whole series of problems outside of the respiratory tract, and I'm not going to dwell on them at any length here, but just to make the point that a lot of people describe CNS related symptoms, and we do know that in the acute state you do see inflammation in the brain. This is a MR scans on somebody with a showing leukoencephalopathy in the context of acute COVID-19, and there are ongoing structural imaging studies, including some we're doing in Nottingham, looking at whether or not patients with long COVID continue to have abnormalities on imaging. Similarly, this is just another example. The kidneys are affected in the acute disease. This is part of a collaborative study we've been involved with Uppsala University. So in Uppsala, they were able to do MR scanning, looking at renal blood flow on the ICU. We've been helping them analyze some of those scans to get a feel for renal physiology in acute COVID, but we also have an ongoing project where we're looking at people who have been left with renal impairment post-acute COVID, trying to understand what the longer term consequences in terms of kidney and indeed other intra-abdominal organs are from having had an acute illness with COVID. In order to sort of coordinate these and other efforts, there are some national studies which are ongoing. Probably the best known of those is FOS-COVID, which stands for post-hospital COVID. This is a multi-center study looking at the longer-term effects of COVID in those who were hospitalized with more severe disease. There's a whole series of assessments at 6 months and further follow-up. And in Nottingham, we've been leading the lung fibrosis part of that, and we've just had a fairly large UKRI grant awarded to Gisley Jenkins to undertake some novel imaging looking at long-term follow-up. This obviously captures the hospital population, but it doesn't capture the people I mentioned earlier, those who weren't sick enough to come to hospital in the first or second phase, but are being left with symptoms. And so I think there is a gap out there in terms of primary care follow-up. We've tried to plug it locally by setting up a primary care research clinic, and so we have the commissioners who have funded primary care to refer patients who were poorly from in the first phase but not sick enough to get to hospital, who've been left with symptoms, and we've actually been inundated with referrals, and I think this is quite a challenging space because on the one end of the spectrum we're seeing people who've got clear structural disease such as that I've shown you on some of the images here, who following an acute episode of COVID. On the other end we've got people who have got a whole series of symptoms which in the past before COVID would probably have been labeled as chronic fatigue syndrome. And then in the middle, there's a sort of a grey area where we're not completely sure how much overlap there is between some patients who've got symptoms which have some features more related to sort of a chronic fatigue syndrome and those who've got very clear structural damage. And that I think is an area which is going to be very important for us to sort of delineate. And of course, one of the potential hopes here is that by understanding better the pathophysiology of long COVID, we might gain insights into these previously rather nebulous conditions labeled as chronic fatigue syndrome and ME. That would be I guess a good outcome if we understood more about those conditions, which cause us all a lot of difficulty from a clinical point of view. So that's a very rapid run through on where we are, both in terms of COVID at present and some initial thoughts about long COVID, what it looks like, and what it's going to mean in terms of workload for both the primary care and the secondary care sector. So just to summarize, what the initial effort was all about, the acute management of COVID, quite reasonably, actually, as vaccination rolls out, and we have, well, it will continue, I'm sure, to have a steady trickle of patients each year with COVID coming through hospitals, either because they haven't been vaccinated or because of different strains becoming predominant. It's going to be these long-term consequences which potentially are going to be the larger part of the workload as we move through this autumn and beyond. We got a great infrastructure in the UK which has been able to coordinate activity. I've highlighted the biomedical research centres, but actually it goes beyond that. The whole of the NIHR infrastructure has managed to make sure that we have a coordinated effort nationally to both research and to do intervention studies to find out more about these conditions. And I think it's absolutely true that the UK has led the way in terms of, particularly I think, of the interventional studies. And as I mentioned briefly, there's a new national platform which is going to facilitate research into long COVID. And I can tell you that we made a decision today for the first drug to go into that platform, so that it's not in the public domain yet, but will be announced fairly shortly once the CMO has ratified our decisions about that. So I'm going to stop there. I'll hand you back to Will, who I think is going to be responsible for moderating the questions, and appear to be 13, so I'll rattle through as many as I can do. So over to you, Will.
So Ian, thanks very much for a really good overview of some of the complexities of long COVID. Could we start at the beginning with a case definition?
Yeah, so the one that's generally used is one which is ongoing symptoms and signs which relate to a previous episode of COVID which persists beyond a month.
But as I understand it, then I think it was the NICE guidelines don't specify that you have to have had a positive SARS-CoV-2 result.
Yeah, so the problem with I think the big problem here is that the amount of testing that was being done back in the first wave, Will, was pretty minimal, as we all know, and so there are an awful lot of people who had what was probably COVID based upon clinical grounds, who didn't have a positive test at that point in time.
So would it be sensible to insist on some kind of serology?
So I would be, so we don't know how long the antibody responses last for. There are people who have had episodes of COVID and whose antibodies have fallen over time, aren't there? So, but I do think it would be a reasonable screening test, yes, because it comes back to this question of, I was sort of hinting at, where there's these overlaps, I think, between long COVID, which is clearly being driven by abnormalities that you can pick up in imaging or lung function tests or whatever, biomarkers, but another group of patients who may not have those abnormalities, who previously would have been given different labels, I suspect. So I think that if you have symptoms but no evidence of positive antibodies, that it's going to be much more difficult to be clear that that individual's problems are related to specifically to acute COVID.
Yeah, somebody's phrased it quite nicely, that how do you differentiate those with long COVID and those who get long-term complications from COVID? Are those two separate?
So I think that's exactly right, and so I think it's easy if you've had someone who's had a prolonged ICU admission, has basically had COVID-related ARDS, who's got structural lung damage, and previously, if they'd have been to, as I said earlier, that if it's some equivalent to what you see in someone who's had flu A, for example, and ARDS on an ICU, then so some of those. And we know the natural history of ARDS, and most people do improve with time. So I think there will be a group of people who've had a severe illness, gone to ICU, who will have some pathology which isn't specifically COVID, but related to a prolonged hospital stay with multi-organ sort of issues, who will improve. But then they're going to be this other group of people who didn't go to ICU, who've had an acute episode of COVID, where you're seeing these long-term structural things, and that clearly is long COVID, I think. But untangling the two for someone who's been through ICU is tricky.
And are there any promising biomarkers that might distinguish the genuine long COVIDs from what we previously called chronic fatigue?
Yeah. So I'm not an expert in chronic fatigue syndrome, so I'm not going to pretend to be. But I mean, my understanding is that to get a diagnosis of chronic fatigue syndrome, you wouldn't expect to see elevated markers of inflammation, at least in the sort of routine things like CRP, etc. And it does appear that at least in a subset of patients with long COVID, you can pick up some laboratory abnormalities. Now, I think we need to do quite a lot more work to find out whether or not there are more subtle things. So, we could, for example, be looking at highly sensitive CRP rather than just ordinary CRP measurements, etc. And I think particularly looking at inflammation, I mean, given that fatigue and muscle problems seem to be a long-term issue here, there's ongoing work looking, for example, using MR spectroscopy approaches to look for evidence of abnormal muscle behavior. So we might be able to pick up some imaging markers or other biomarkers which give us a bit of a handle on that, but it's obviously a bit early to be able to answer that question.
Okay. A couple of questions about the virus and the patients with long COVID. So is there any evidence that these patients continue to be infectious and can transmit? And a related question, an interesting one, is there any evidence that these patients can get either reinfected and suffer relapse, or that perhaps virus that's already been there can reactivate? I mean, we're getting into difficult areas here.
Yeah, so unless you're so the majority of people who are not immunocompromised, I'm not aware of any evidence that if you have long COVID, you are an infection risk to anybody else. And indeed, there's little evidence that you can recover live virus. I will paraphrase that with just one comment about the gastric COVID sort of subset. I think there's a question in there about it, in that there's a little bit of evidence from a very recent paper I've seen suggesting that you can recover virus in the GI tract at a slightly longer time point than you would expect to in that group of patients. I'm not aware of any evidence to suggest that it's a transmission risk, but it may be too early to know that for certain. If you're immunocompromised, of course, you can shed virus for longer periods of time. So the second point was about whether or not if you've had long COVID, you're at increased risk of being reinfected. I'm not aware of any evidence that that is the case. And the third point is about comments, I guess. So there is a little bit of evidence to suggest that if you have had a severe episode of COVID in the past, that when exposed to the vaccine, that you're at slightly increased risk of side effects, suggesting that you may have a increased inflammatory response to the virus, I guess. So that might suggest that if you were reinfected at a later stage because a different strain of the virus is circulating, then I guess it's conceivable that you might have a more profound inflammatory response second time around as well. But that's purely speculation. There's no evidence I'm aware of on that.
Okay. So let's deal with the gastric COVID. And it's interesting, while you were talking, it reminded me that the original SARS-CoV in Hong Kong in 2003 was associated with spread from the GI tract, and perhaps that's underappreciated, and this is a related virus. So in your cohorts of long COVID patients, do you have patients who only have prolonged GI symptomatology?
Yeah, I'm aware of it. So I think I showed on the systemic systematic review that about 12% of people have ongoing GI symptoms. I'm aware of some data suggest it tends to be people who had an initial GI presentation, and of course I well remember back in March, April, we were seeing people coming through ED who were not suspected to have COVID, particularly some of the elderly patients actually who had GI presentations, and suddenly we started to wake up to the fact that you do get these atypical presentations. So I'm losing track of the question now, actually, Will. So, but yeah.
It is a recognised feature.
Yeah.
Okay.
And I think it seems to be a fairly specific subset.
Yeah. Any evidence from the recovery trial that patients who are given dexamethasone are any less or more likely to suffer long-term consequences?
Not at the moment. So I've asked those questions of Martin Landry and colleagues. There are follow-up studies being planned. I think one key question which is being debated is whether or not there is logic in those who have ongoing evidence of low-grade inflammation as to whether or not steroids would work in that setting. So I'm aware that there is some off-label, well, it's not off-label, I'm aware there is use on a single patient basis of steroids in that setting. And I think that one of the urgent things we need to do in the post-COVID research platform is to look to see whether or not there is a role for short course of prednisolone in that setting, for example.
Okay. Some more specific questions here. Is long COVID described in children, and if so, how does it present?
So I'm not a paediatrician. Obviously, the vast majority of kids who had COVID have very little in the way of symptoms. I'm not aware from talking to paediatric colleagues that this is an issue in the very young. I think there are individuals in the sort of teenage and early 20 years where these symptoms have definitely been described. So there may be a subset of older children, I guess, but I don't have any data on that, I'm afraid.
Okay, two questions on recurrent herpes, either herpes simplex or shingles. Is that described? I mean, the problem there is that you've got a debilitated patient, so you might expect an increase.
I'm not. I have to say that's an area I know less about. I'm not aware of data that there is a markedly increased risk of either of those in patients who specifically defined as a long COVID group. That's not to say that it may not happen, as you say, coincidentally, I guess.
Okay. I think we got asked this question last week, but it's an interesting one. Will there be another trial of convalescent plasma that started earlier in the disease, in the infection?
Okay, I got to be a bit careful what I say here because we've been discussing this at UK CTAP actually. I'll give you some broad reflections. So the final results of convalescent plasma in recovery, there are some continued analyses ongoing which are going to be released very shortly, is my understanding. I think there is a logic potentially in using some way of neutralizing the antibody approach before at an earlier stage in disease, and there are three ways of doing that. One is convalescent plasma, one of them will be monoclonal antibodies, and the third option will be to use hyperimmune globulin. My personal view is that if you had a choice, you'd probably go with the monoclonal rather than convalescent plasma. So there could be a role for doing something in earlier stage disease. And my personal view is if I had to pick somewhere to go, given the potential complexities of giving these agents, you could potentially do IM if you have high enough concentrations of monoclonal or hyperimmune globulin, but with convalescent plasma, obviously it's going to be IV, and that is challenging in a non-hospital setting. My view is that the best place to go with this might be nosocomial infection. So I could see a strong argument for doing a study in patients exposed as soon as they test positive in a hospital setting where the logistics would get easier. But I'm not sure I'd use I'm not sure I'd use convalescent plasma. I think I'd probably opt for one of the monoclonals.
Okay, thanks. Some very specific questions about organ involvement. Any cardiac symptomatology?
Yeah, plenty of evidence for that. In acute disease, you see elevated cardiac enzymes. You also see evidence of myocarditis, and some of those patients, some of the kids, for example, with a sort of TIM type syndrome, have clear evidence of cardiac dysfunction. There is secondary effects on the heart because of thromboembolic complications of this disease as well. There is reasonable evidence that there is decreased cardiac function in at least some people with long COVID, and elevated BNP levels in a minority of those individuals as well. So I think that some people get a myocarditis, and that leaves them with potentially longer term consequences leading to heart failure.
Okay, patients with headaches, should they be further imaged? There are apparently reports of changes identified at post-mortem in the brain.
Yeah, tricky one. I think something like 50% of people in the systematic review had headaches. I'm not sure you'd want to be imaging all of those people. I think you probably need to have some sort of triage process. And just because you've had COVID doesn't mean you haven't got a more sinister cause for your headache. So I think my view is you wouldn't routinely image all those. You'd be selective as to those you would image. Those who had other features which suggested that headache might not be related to COVID, or those who had ongoing very severe symptoms for which you had no adequate explanation.
Okay, two diametrically opposite questions about vaccines in long COVID. So one is, are there patients whose symptoms disappear after they get a vaccine? And the other says, should patients with long COVID not be vaccinated?
So I'm not aware, it doesn't mean it doesn't happen, I'm not aware that people who've had the vaccine who got long COVID symptoms disappear. If anything, there's a bit of evidence to suggest they're at risk of an increased, slightly increased number of side effects. I've seen some preliminary data on that. Do I think that they should not be vaccinated? I think that at the moment, any potential risk, which, as I said, at the moment seems to be related to short-term side effects rather than anything else, is likely to be outweighed by the advantages of being vaccinated, particularly as new strains become prevalent.
Okay, back to specific organ-related symptoms. Any cases of adult-onset asthma?
No, is the simple answer that I'm aware of. So I will give us a longer answer to that. So many people who've had a viral illness are left with a period of airway hyperresponsiveness afterwards, and I see many of these people in my asthma clinic actually, and they don't tend to respond very well to asthma treatment, and it tends to get better over a period of 6 to 12 months. The predominant respiratory complications appear to be this sort of interstitial lung disease, which has been which I showed you images of earlier, rather than asthma-like symptoms. Interestingly, there was a worry in the early stages that asthmatics might be at increased risk of severe outcomes from COVID. That doesn't appear to be the case. In fact, there's a little bit of data from some countries suggesting they may be at slightly reduced risk. And coupled with that is the possibility that the medications that we use for maintenance of patients with asthma, i.e. inhaled steroids, etc., could potentially be a benefit. And there is an inhaled steroid trial going on in early disease, I understand.
Okay, autoimmune phenomena, increased or not, and might that give a hint as to what's going on?
Don't know the answer to that. I mean, there are plenty of sample collection studies ongoing which will give us the answer to that, I suspect, but I don't know specific data. There may be some out there which I haven't seen.
Okay, one very specific question. Have you seen swollen tongue with scalloping? I'm not sure what scalloping is, swollen tongue.
So I haven't seen it, but I have seen that described actually, sort of glossitis type picture in certainly in acute disease. It's been described. I can't remember where I read that, but I remember seeing a couple of case reports of that.
Okay, and something we haven't touched at all, hormonal imbalance, e.g. women with menopausal symptoms. Has that been studied?
I don't know about that, I'm afraid. It's not predominant in the, it probably wouldn't have been captured by the sort of long COVID systematic review. And I have to say that the systematic review, although it claims to be systematic, is based upon generally fairly poor quality studies with a lot of heterogeneity. So I think there's more work to do in that space. I don't recall them capturing any particular issues in that patient group.
Okay, I'm getting increasingly hysterical messages saying that I'm going to have to wrap up in a minute. We have actually knocked down the question list. There's only 6 remaining, but I think you've addressed 3 or 4 of these. So, okay, can COVID cause long-term mental illness?
So I think the jury is a little out on this one. I suspect that there's undoubtedly a group of people who previously had a history of mild anxiety, depression, who've been made substantially worse by having had COVID, and I think that there's going to be a large amount of morbidity as a consequence of COVID, which is going to cause a major strain on the system. Whether or not somebody who was previously entirely well can develop as a consequence of CNS changes, new mental illness, mental health disease, I'm not absolutely sure, to be honest. Well, it wouldn't surprise me that much, but I don't know of any specific examples.
Okay, the very final question, I will make this the last question, but I do think it's an important one, is are there individual patient groups that are more affected with long COVID? Is it the same as with COVID? Is it related to ethnic minority? Is it age related, gender related?
So I think partly long COVID is undoubtedly commoner in people who've had more severe disease. So therefore, there will definitely be groups of patients who are at more risk of a more severe acute disease who are going to be more likely to get long COVID. But there are undoubtedly, as I've hinted at, as I said, there are those groups of people who otherwise have been entirely fit and well previously, who seem to have had COVID and been left with symptoms. I get regular emails and indeed referrals about people who used to be able to run marathons who now find themselves really quite disabled, who've been previously entirely fit and well in the past. So I think that the observational studies with a long-term follow-up and sample collection, etc., will be the way to get an answer as to whether there are subgroups. I will be very surprised if there are some genetic factors which predispose you towards getting long COVID, much as there are in acute COVID.
Okay, well, thank you very much indeed. I've thrown a barrage of questions across every organ system I can think of. Thank you for dealing with that. Thank you to the audience for such a huge pile of questions. We got through most of them. There are 1 or 2 maybe left over. I might ask Ian afterwards if he can come up with a quick reply and we can post something on the website. But thank you very much again, Ian. To the audience, thanks for turning up. Thanks for your questions. Next week is the last of the series. We will have Mike Osborne, who's the president of the Royal College, talking about the pathology of SARS-CoV-2 infection. So please do re-register for that one next week. And with that, it's a good evening to all of you, and I hope you enjoy the rest of the evening. Thank you very much.